Okay, the webinar is now live.
Addressing the huge population needs. I look forward to this event and welcome again. Thank you. Over to you, Larkas.
Thank you, Bente, for these opening remarks and also for emphasizing the need for strengthening workforce in rehabilitation and also the potential of the Rehabilitation Competency Framework to send a strong message of unity if all rehabilitation professionals use it. So now let's move on to the first section, to the section on the why. And on the why and the what, starting with the why. First, why are competency frameworks relevant for workforce strengthening? James Buchan will introduce that, and James, you have the floor.
Thank you very much, Alarkos. I'm very pleased to be able to contribute to the launch of the framework. I think it has tremendous potential, and there's two real key issues I think it can contribute to. One is the contributing to raising the visibility of the workforce in rehabilitation, and secondly, contributing to demonstrating its value. I have only a few minutes, so I will be brief and to the point. In terms of my presentation, I'm going to cover those four issues, look at the context quickly, define what we mean by competent, but spend more of the time on issues related to developing a shared understanding of the contribution of the rehabilitation workforce, and finish looking at some of the potential benefits and key messages of using the competency framework. The context, you all are very aware of the context. I'm not going to spend too much time on the background, but we obviously are in a situation where the increase in NCDs, growing population, combined with the more immediate effects and likely longer term effects of COVID are all highlighting the need to invest in the rehabilitation workforce. Secondly, we're also aware through the work that you and others are doing about the extent to which there are not just numerical shortages within the workforce, but also issues related to geographic distribution, sectoral distribution, and the need also to focus on issues of quality and relevance within the workforce. And finally, shortages are often defined as numbers, but it's not just about numbers, it's about skill mix, it's about efficiency and performance of the sector. I was very pleased to see a nice, clear definition in the framework in terms of what competent and competencies are. I have academic colleagues who seem to spend their whole career defining and redefining, and rather than getting beyond a definitional dead end. So it's good to see a clarity of definition, but then very much a framework that's moving beyond that, looking at the critical issues that we need to have a better understanding of in terms of articulating the knowledge, skills, framework, and behaviors required for the workforce to perform a range of activities in the provision of care that people need. The key point there is the care that people need. It's driven by a recognition of population need at the start of the process. As I mentioned, competencies are sometimes regarded as something that's academic and only really about education, but it has the potential to provide a common language and develop a shared understanding between the populations that are being served by the workforce, but also employers and the various other professional education and training bodies that are part of the process of deciding how many and what types of workforce within rehabilitation we will require to meet population needs. Just to emphasize this point of developing a shared understanding, if we have a framework and everyone is connected into it, it provides the ability for the different stakeholders to share a language, develop a better understanding of the numbers, types, and profession within the workforce, where they work in terms of sectors and locations, what they do. This is the main focus of the framework, skills and competencies, but also it provides the opportunity to then look at outputs, outcomes, and money saved, because if we're talking about investment, we're also going to be demonstrating value. Invest in the workforce, it will improve outcomes, outputs, and overall will save money within health systems. There are a range of different benefits that potentially relate to the application of a framework, and I'm not going to go through this in detail. Jodie will have time to do that, and the framework itself sets these out nicely, but there are issues about supporting, promoting multidisciplinary working, ensuring a better integration of services, avoiding fragmentation, underpinning new ways of working, and providing a more structured career path. And also beyond that, looking at issues to do with identifying gaps in the workforce, particularly when it comes to sustaining universal health coverage. Just going to conclude my brief contribution with two final slides. These are really, for me, the key messages, the key takeaways that we can consider as the potential through effective application of the framework. There is, as never before, a need to invest in the rehabilitation workforce in terms of population demand growing and accelerating due to the likely impacts of long COVID. So the framework, as I said, can allow the different stakeholders to develop a shared understanding of the value of the workforce, and that in turn can drive investment. Secondly, there's the opportunity to look at how we can solve some of the identified workforce challenges. And this isn't just about numbers or shortages, but it's also looking at the necessary knowledge, skills, and behaviors to meet identified population needs. Finally, the competency framework can provide the mechanism for aligning the workforce profile with the needs of the population. This is probably the central aim of the framework. And if you then think that through, that then leads into the fourth point here, which is it provides one of the foundations, one of the key building blocks for workforce development. It has potential across all the major policy interventions around health workforce: training, regulation, needs assessment, recruitment, retention, performance appraisal, and can also contribute to improving the approach to evaluating the workforce and also planning the workforce. Huge potential. It's not all nearly being fully implemented yet, but I would like to congratulate WHO on moving forward with this for a part of the workforce which is critical, but in some cases has not had the visibility it deserves, and therefore not had the value attributed to it that it also deserves. And I think, as I said right at the beginning, we have a framework here which can help increase visibility and develop a better understanding of the value of the workforce. Thanks very much. I look forward to listening to the other contributors and also perhaps taking questions later on. Thank you.
Thank you, James. Your presentation is extremely appreciated, and also for really bringing at the end these essential key messages. So now let's move on with the what. What is the Rehabilitation Competency Framework and its development? And I would like to give the floor to Jodie Mills, who has been and is the driving force and leading this process, has been the driving force leading this process, and also addressing all relevant issues in terms of rehabilitation workforce. Jody, you have the floor.
Thanks, Alakos, and hi everybody. It's great to see so many of you joining us from around the world. We embarked on developing the Rehabilitation Competency Framework back in 2018, so it's incredibly exciting to finally be able to share it with you. I just wanted to make a couple of quick points before I really get into this. Firstly, I've seen a few people that are raising their hands. I would just advise you to put any questions that you have along the way in the chat box. The team will be going through all of those questions after the webinar, putting together a fact sheet, and we'll distribute that to all of you so that all of your questions are answered. We just can't sort of answer them live as promptly as we would like to. The other thing is just to say that we use the acronym, the RCF, when talking about the Rehabilitation Competency Framework. And so I will probably revert to that throughout my presentation. So I hope that that doesn't cause confusion for anyone. I've been tasked with, as Alakos said, tackling the what of competency frameworks. Sorry, my slides have just jumped ahead. In a nutshell, I'd say that the RCF is really just a description of how rehabilitation workers behave, so their competencies, and what rehabilitation workers do, or their activities. And it also captures or articulates their knowledge and their skills and some of their core values and beliefs. But a more technical or comprehensive definition would say that the RCF is a model that communicates the expected or aspired performance of the rehabilitation workforce to enable quality care and service delivery. If you're like me, I find it best to really get a hold of what something is by actually seeing it in front of me and really exploring it and getting a sense of what it looks like. So if you haven't done so already, I'd encourage you to download the competency framework. It's available online, and spend some time just exploring it yourself. But I have tried to sort of capture bits and pieces of it in this presentation to give you some more concrete examples of what that looks like in this competency framework. So who is the Rehabilitation Competency Framework for? Well, one of the defining characteristics of the RCF is that it is relevant to all rehabilitation professions or cadres across all specializations and in all settings around the world. So in short, it's relevant for all rehabilitation workers. And if you were to actually go through the RCF, you would notice that we don't make much mention at all of specific rehab professions or specializations. And this was very intentional. We wanted to make the framework agile and as neutral as possible so that it could be taken up and adapted by all sorts of different groups of rehabilitation workers. You could probably liken it a little bit to a baker's pantry, where it has all of the ingredients you could possibly need, whether you are wanting to bake a loaf of bread or make a cake or make chocolate brownies, regardless of what sort of composition of ingredients you needed for your product, you would find it in that pantry. And that's quite similar to how the RCF works. So why was the RCF actually developed? There were three key reasons. First, we found that really where competency frameworks are needed most, they didn't really exist or were only really just starting to emerge. And so we wanted to create a launchpad from which context-specific rehab-related competency frameworks could be developed. And just facilitating that process and hopefully having a stronger, really good quality framework at the end of that. The other reason was that there wasn't really a competency framework that shared or that captured the rehabilitation workforce collectively. So we wanted to create a framework that really filled that gap so that we could start to implement competency-based approaches and things like workforce-wide or rehabilitation workforce-wide and interdisciplinary evaluation, planning, and practice. And we've already started to do that, actually. We're integrating competency gap analysis into a rehabilitation workforce evaluation tool that's under development at the moment. And that's the kind of thing we wouldn't have been able to do before. Finally, when we were looking at competency frameworks, we noticed that there's huge variability in their quality, their language, and their concepts. And so we wanted to address this by providing one reference framework to help improve the communication amongst the rehab community. And just quickly, how is it actually developed? I'm going to have to really brush over this just for the purpose of time, but you can find all of the finer details of this in a couple of publications that are available online, and I'll show you where you can find those. But essentially, it took 5 key steps: a scoping review of the literature, a content analysis of existing rehabilitation-related competency frameworks, a Delphi study to build consensus, and a service user consultation, and finally, the integration of condition or health condition-specific tasks into the practice domain of the framework. So the scoping review was really conducted at the start to get some conceptual clarity before we jumped into actually building the framework itself. We found that even the question of, and Jim alluded to this just before, even the question of what is a competency seems a topic of hot debate, and there's huge variability in the definitions used. So we got together with some of our colleagues across other departments that are also working on competency-related work and undertook this review together and came up with an agreed sort of glossary of terms that have set definitions that we can apply across all of our work. And that was a really fundamental starting point for the Rehabilitation Competency Framework. You can find the details of that scoping review in the publication that we published in the Human Resources for Health Journal last year. The link's there, but it's also on the RCF webpage, so you can access it easily from both places. The next step was a content analysis of existing rehab competency frameworks. So we gathered these from a range of sources, including Google, academic databases, and also a call out that we did to international professional associations and some health condition specific organizations who shared frameworks from their networks with us. And we basically sifted through these and we started to identify common themes and topic areas that allowed us to build a kind of first list of the competencies, behaviors, and activities and tasks we wanted to include in the RCF. And also to create a structure. So we explored all the different thematic organizations that they used and found one that was going to work best for the RCF. And when we started mapping that list of initial competencies into that structure or that architecture, we were able to establish the very first draft of the RCF. Again, I can't go into the details of the content analysis, but you can find them in another publication that focuses specifically on the development of the RCF, and that's also available on the RCF webpage. It was at this point that the RCF Technical Working Group really came into full force. So this was a group of 20 experts from across the 6 WHO world regions, although there was a big dominance from the Americas and from the European region, because this is where competency frameworks originated and it remains where they are dominant in the world today, and hopefully that will change in future. They also represented all of, or many of the core rehabilitation cadres that you see listed there. And some of them also are people with a disability and who have experienced extensive rehabilitation in their own lives. So they were able to offer that experience or that perspective to the process as well, which was really valuable. The third step was a 2-iteration Delphi study, which is essentially a survey that you do back and forth to try and build agreement on the content of the framework. We had about 80 participants involved in that study, so we were able to get a much wider range of perspectives from a greater geographical representation. By the end of that study, we'd achieved over 95% agreement of the contents of the competency framework across all domains, which we were really happy with. And then the service user consultation. This is where we wanted to get the perspective of people that use rehab services, and we wanted to get their feedback on the core values and beliefs of the competency framework, which I'll explain a bit later, as well as some of the specific competencies and behaviours. On the whole, the people that responded to our survey really confirmed that they were happy with the content, but they really wanted to emphasise the collaborative nature of rehabilitation. And so we made that more explicit by adding it in as an additional core belief for the framework. And again, you can find all of the details of these specific steps in that development publication online. The fifth step is yet to be completed. This is where we will be going into a lot more detail about the specific rehabilitation assessments and interventions. So really focusing on that practice domain. But we'll be integrating these from the package of interventions for rehabilitation, which has just been developed by our program at the moment. And we're hoping to have it ready by the end of the year. As you can imagine, as we add in more and more specificity and detail, the framework gets bigger and bigger. So this version will be available only through an interactive web platform that will allow you just to navigate really easily through all of the content. So jumping into the fun stuff, what does the Rehabilitation Competency Framework actually include? This figure sums it up quite nicely. You can see it includes 5 domains, we call them: practice, professionalism, learning and development, management and leadership, and research. So we go into the competencies and activities in all of these areas. I won't go too much into what each of them is about, because I think the names are fairly self-explanatory, but all of them revolve around core values and beliefs, which was felt to be really central, especially for a framework that is shared by the whole rehab community. And within each domain, you'll see a fairly similar structure where we define the competencies, activities, and the knowledge and skills relevant to each domain. And I'll show you a little example of that in a minute. In many ways, the RCF looks like many other competency frameworks in terms of how it's structured, but it's a bit different in that we do differentiate between competencies and activities. That can seem a little bit confusing, and I'm not going to dive too deeply into it now. There's a table in the framework that I've copied here that explains it quite well. But just to highlight that the competencies, which are the sort of innate abilities of a rehabilitation worker, things like communication, being person-centered, collaborative, being able to problem solve, these things we say in the RCF are relevant to all rehab workers, regardless of your profession, where you work, who you work with. We share them as a rehabilitation workforce. The activities, on the other hand, and the name's quite intuitive here, these are the tasks that we undertake, the things that we actually do. And which of these are relevant to what rehab worker will really depend on their role. So if you were adapting the RCF to make your own competency framework, you would have to sort of pick and choose which of those was relevant to your workforce. One of the other ways that we make the RCF relevant to the whole spectrum of the rehabilitation workforce is by describing 4 levels of proficiency. These aren't perfect, but they do give us a general picture of the spectrum of performance that you can see across the rehab workforce. We start at level 1 and move to level 4, and basically you're seeing an evolution in the level of autonomy of a rehabilitation worker from level 1 to level 4, as well as the depth of their knowledge and mastery of their skills, and an increasing level of specialization as you go up. What's important to note, though, is that these levels don't align with any specific cadre or profession, or indeed with any specific length of education or training. You could, as a rehab worker, see yourself reflected in a specific level in one area and in a completely different level in another. And it'll probably change over the course of your career as well. But having that full spectrum available means that when you're adapting the RCF, you have a nice range of ingredients to pull from. And this is just an example of what we call a proficiency profile. So at the start of each domain, we try and paint a little bit of a picture of what a worker at each of these levels would look like, so that you can better understand how the different behaviours and tasks would be divided amongst those different levels. And here you see an actual example from the practice domain of the Rehabilitation Competency Framework. So I've just pulled out a couple of the competencies and just a few of their behaviours to show you how it looks. So you can see for one of the competencies that it's described, the behaviour is described at each individual level. And for another, where they're talking about working within your scope of practice and competence, it seemed that that behaviour would look the same across all 4 levels. So it's just described uniformly across all of them. But here is where I would say, have a look at the competency framework and get a real sense of how that works in practice. Finally, the knowledge and skills. These really underpin the competencies and activities. So they're a really important part of the framework. And the RCF includes both core knowledge and skills, which really pertain to the competencies and behaviours that belong to all of us, and activity-specific knowledge and skills, which are obviously going to be important to some and not others, depending on what your work involves. And I wanted to finish off with just some important points. Firstly, that the RCF is a lot more than a series of organised lists and tables, which is what it can look like superficially. It's actually providing an alternative lens through which we can see the rehabilitation workforce. And often when we think of the rehab workforce, we think very much of different professions, and that's important and very relevant. But it's nice to have an alternative competency-based lens because we often need it in contexts where the rehab workforce is really lean, it's just emerging, there are major competency gaps, and countries have to be very efficient and strategic and sometimes innovative in how they delegate competencies to make sure that everybody gets the rehabilitation that they need. Secondly, the RCF focuses very specifically on the rehab worker, but rehab workers don't exist in a vacuum. They work in environments that will either hinder or promote their performance. So in a country where you're wanting to develop the rehab workforce, the RCF will be only one of many different tools and strategies that you would need to apply. You can't just address the rehab worker, you have to address the whole environment in which they practice. And finally, the RCF does not stand alone. It was published along with 2 guides for its application. One for adapting the RCF to a specific context, and one for using it in the context of rehabilitation education programs and their curricula. And these go into quite a bit of the nitty-gritty and the detail of the process. So we'll actually be holding individual trainings for each of them. The first one on the 11th of March and the second on the 25th. But we'll send you all of the details for those trainings in an email following this webinar. And you can also keep an eye on the RCF webpage because we'll be advertising them there as well. And I couldn't finish without thanking all of the members of the RCF Technical Working Group, and I hope many of them are on the webinar tonight. This group was incredibly committed and put in a huge amount of their time over the last 2 years. They were really critical when they needed to be and really supportive when they needed to be, and just added really brilliant expertise and experience to the whole project. So I very sincerely mean it when I say that we couldn't have done it without them. And I will leave it there. Thank you very much.
Thank you, Jodie, for your clear presentation, and also thank you to all technical working group. Fantastic to see this work moving forward and having now the results of work of over 3 years. But now let's move on to the how and the applications of competency frameworks. And I will pass the floor to Jim Campbell, the Director of Workforce here at WHO. And Jim, it's really a great pleasure to have you with us. You and your colleagues and your department has accompanied us through the whole journey of Rehabilitation 2030 since its outset in 2017. And it has been great working with you and all of your team over these 3 years. So thank you also for being with us already at front. Now, the floor is yours.
Many thanks, Alagas, and to our colleagues from the department, to Jodie and Jim for their presentations. It's delighted that I can join with you today. As Alagas has said, this has been a journey with the team. not just on to celebrate that journey, but also celebrate the International Year of Health and Care Workers, with now more than 550 of you who decided to join with us your Friday mornings, your Friday afternoons, your Friday evenings to discuss the Rehabilitation Competency Framework. So Jody just mentioned we have testimony to the RCF Technical Working Group, and it's a pleasure to be joined today by two of the members of that group. And I'd ask both Mary and Harvey if they can put their cameras on. We have with us Dr. Mary Silcock, who is a practicing occupational therapist in New Zealand and working for many, many years in that work there. She's been involved in particular on the regulation of the profession and looking at how to develop competencies for registration in that environment. And now she's working on, or has been working recently, on implementing those into practice as a professional advisor. And she's currently working with the Ministry of Health as part of the COVID-19 response team. We're also joined by Professor Harvey Abrams, who has a distinguished career over 4 decades, working in academia, in clinical and research and management capacities, consulting also to government, industry and academia. He's currently a professor in the Department of Communication Science and Disorders at the University of South Florida and serves as the head of research audiology with a teleaudiology focused company. And both of those have been instrumental in the technical working group. Indeed, we've heard the what, we've heard some of the why. Now we're going to focus on the how. So with people with this practitioner experience, I'm going to turn first to Harvey. Clearly, we see from Jim's messages and from Jody's messages the how, why we need to align with workforce needs, why we need to make the connection. Obviously, then, how do we do that? Why is a competency framework so integral to trying to drive change in education and lifelong learning? But also, sometimes, why is it not enough? Harvey.
Well, thank you so much, Jim. I appreciate the opportunity to address the working group and the panelists and everybody who's joining us today. I'm really impressed with the attendance. So in terms of education and training, I think it's important to understand that pre and post-service education is where rehabilitation workers truly acquire much of their knowledge and their skills and their behaviors. And they need these to safely and effectively perform the activities that they're being trained for. So if we want to make sure that the workforce is equipped to meet the needs of the population, we have to ensure that those knowledge, skills, and behaviors, and what we collectively are calling competencies, align specifically with population needs, and also enable the workforce to perform in all the various settings where they're most needed. So for example, a rehabilitation worker based out of an orthopedic ward in a tertiary care hospital is going to need an entirely different set of competencies when compared to a rehabilitation worker in a primary healthcare setting in a rural or remote setting. So these pre and post-service education needs, they need to be aware of the competencies required, make sure the rehabilitation workers develop them. And the competency frameworks are where we define these required competencies. They're developed by considering what specific competencies and activities are relevant to that specific workforce, aligning them with population needs, getting consensus on this, and then making sure we record them so they can be clearly communicated across the population and other stakeholders. So simply put, competency frameworks are a mechanism for ensuring that education and training develops rehabilitation workers that can effectively meet population needs. So I hope you can see kind of the linear relationship here. But it's important to understand that these frameworks aren't all that it takes. Imparting these competencies to learners requires a lot of infrastructure and human capital, including qualified faculty. And that in turn requires a lot of political will and long-term investment. So competency frameworks are an important and critical tool in rehabilitation, workforce education, and training, but truly they're only one piece of the puzzle.
Very interesting there, Harvey. You mentioned that obviously a piece of the puzzle, and we need to, you mentioned the infrastructure needs, the faculty needs, and that's the translation. I mean, WHO issues guidance, normative guidance, which is the evidence, the best-in-class evidence at a given moment. How do we make sure that evidence is translated into practice? How do we make sure those investments that you spoke of are driven forward? What's your guidance to our audience today on that?
Well, the competency frameworks define from an educational perspective, they essentially drive the curricula. They capture what competencies a learner will have to acquire at a particular point, such as graduation, or perhaps a conclusion of an internship. So in competency-based education, these learning outcomes are translated into learning objectives, which shape what is taught and how, and importantly, what a learner is assessed against. These competency frameworks are mainly used during curriculum development, but they can be a useful reference even well after education program has been established. For instance, so learners may want to refer to them to get a sense of what they are expected to be capable of, what attributes are considered valuable for their particular discipline or specialization. Educators can refer to them to review what they are preparing their students for, what they should be exposed to, what they need to prioritize in their learning activities. And furthermore, competency frameworks are critical in determining the extent to which students are prepared to provide safe and effective treatment to the population they will serve. So there's always a risk, of course, that you develop something like a framework like this, a very ambitious project, but it sits on the shelf. But rather than sitting on the shelf, frameworks, competency frameworks should be considered as a living document, because the knowledge and the skills and the competencies required for the safe and effective delivery of healthcare are always changing. They change with new knowledge and they change with new technologies. So educational institutions, ministries of education or health also can refer to competency frameworks to assess the current capabilities or expectations of the workforce, see what mismatches might exist with population needs, and then use these education and training tools to help address these mismatches. So in short, competency frameworks are used by almost everybody involved in education and training, especially, but not only during curriculum development phase.
Thank you very much, Harvey. Let's move across then to Mary. I mentioned that Mary has been working in the COVID-19 response and has a wealth of experience on regulation. We've seen around the world, over 80 jurisdictions have changed their regulatory frameworks in the COVID-19 response as health systems evolve and emerge to that response. So regulation clearly is a very powerful tool that can be used to drive health systems behavior, health systems change. Mary, I mean, sometimes that's not the case when it comes to education. Sometimes there's a bit of a challenge. What are some of your thoughts and experience on how regulation can drive improvements in competencies aligned to population needs?
Yes, tēnā koutou katoa from Aotearoa, New Zealand. Nice to be here, in the middle of the night for me. Yeah, it's an excellent question, because regulation, I think, is well, I don't know if it's underutilized everywhere, but it's underutilized to address the population's needs, because there's a lot of power in it. And I think what Harvey was saying about the practice and ongoing competence is where the regulation really has a really big role to play in influencing practice. And in Aotearoa, it's illegal. We're the legislative. We've got the legislative frameworks behind us to enforce things, and we're there to protect the public. So that is our mandate, the acts that we're under, and I think that is often the case in most global regulatory frameworks. They're set up to protect the service users, to make sure they're getting safe practice. So with the competency frameworks, regulators have a responsibility to regulate them. And it's not just about having a practicing certificate, it's regulating what is competent in the framework. And if that is being always updated and modified to what your population needs, it will evolve and change and respond appropriately. So COVID-19 is a perfect example of that right now. So as an example, for Aotearoa New Zealand, we're a bicultural country with a treaty with the Indigenous Māori people, and we have to regulate in a culturally appropriate way and accommodating the political context that we are working in. And so regulation has that link to the law and that sort of structure. So it's an excellent lever that we can really align with curriculum and change and progress to address a lot of systemic problems that are in practice, because we have another layer after somebody's trained to look at practice.
Mary, I just want to pick up on the point you made there about the local context, the cultural appropriateness of this. Obviously, this is a global competency framework that's been developed on the rehabilitation workforce. How do we therefore adjust this again through that experience that you bring? How do we adjust this, and how do regulatory bodies help implement that in the local context and help to ensure that we're regularly assessing and determining competence?
Well, I think the idea of it being a living document, and you have to be practical about it. You can't always adjust the competencies, but I think you need to write them with the view, a short-term view, 5 to 10 years, and the capacity to adjust quickly if you need to. And with regulation, there's a lot of bureaucracy and processes. So when you are designing a curriculum, a competency framework, the processes really have to be forefront in your mind of how you can easily operationalize those competencies in your regulatory tasks. And we are just going through this now in Aotearoa for occupational therapy. We have really trying to grapple with a new set of competencies for us, and the RCF is going to provide a nice reference benchmark that we can refer to with the language, because Jodie's done such a great job with the language in it. But we have had trouble auditing against them in ways that are efficient and actually make any changes to competence or practice. So having a really clear idea how you're going to audit and measure against your competencies at the beginning, when you're writing them and building them up and making your levels of proficiency, it's really important to sort of think about all those ongoing effects and how the competency framework is actually going to be used. And we find it's a central document for regulation for us on the Occupational Therapy Board, because it guides our new registrations, our ongoing competence and measurement, the professional development we expect of people, and the type of standard that they need to be demonstrating.
Excellent. One of the as part of the year 2021 designated by member states that we recognize all health and care workers everywhere, we've got 3 things: to protect, invest, together. We've mentioned here some of the different stakeholders involved, the togetherness that's required. So quite final question for you, Harvey and Mary, both, if you can, please. How do we actually get in practice the educators, the academics, the deans, with the regulators, the councils, and all other relevant stakeholders? How do we use this tool to drive that togetherness at the national level? What are some of your thoughts and experience on that? And if I could ask you to be quite brief in terms of your responses. Harvey.
Well, I guess you can envision these frameworks as standards in a sense, and truly it serves as a bridge between training institutions and the regulators, because it provides this common understanding of the terminology, of the necessity of meeting the needs of the population, of what's required for education, and what's expected and what's important in terms of rehabilitation workers. And to the extent that the provisions of rehabilitation services are regulated through some certification or licensing or regulatory process, the RCF can serve as an effective bridge, as I mentioned before, among all of these stakeholders as we develop scopes of practice. And those scopes of practice, regardless of discipline, should be driven by the competency framework as defined and taught as part of the education program. So there's this link, right, between the education program, the regulatory agencies, all the stakeholders, the populations, the ministries of health, and so forth. And why this is such an effective tool.
Excellent. Thank you very much, Harvey. Mary, same question.
Yeah, I think that is correct. And I think the competency framework provides a common, but both sectors or all stakeholders have got a lot invested in them. So it actually provide, the service users and the public, the lawyers, the employers, regulators, educators, they all need these frameworks. So it provides that common ground, but it's also an amazing, awesome opportunity to collaborate with these people in a personal way, because they're hard to write, and you can actually get to understand each partner's needs a lot more by actually developing the framework together. And we have found we can partner with Indigenous, our Māori occupational therapists, our other cultural groups, and it gets those relationships at that governance leadership level in the profession. I know we're a small country and it's a bit easier like that, but it does provide the mechanism for those sort of collaborations and partnerships to actually develop into something real that means things for the stakeholders.
Thank you very much, Mary. Dr. Mary Silcock, Professor Harvey Abrams, two members of the technical working group. We gratitude for all your work that you've done. To the audience and the participants listening, some excellent suggestions there, how this is a living document, a bridge, and how Mary said, how to use it as a tool for the personal connections. Language is important. Common understanding and building trust is important. And with those things, we can create change. That in itself is a competence, that leadership and ability to negotiate. But thank you very much to you both. Alakos, back to you.
Thank you, Jim, and thank you to the excellent panelists. So great enjoyment hearing all the explanations that you have provided. And also, Jim, thank you for reminding us that we are celebrating the International Year of Health and Care Workers, and that this event is also a mechanism to celebrate this year. So thank you for that too. And now we move on to our questions and answers session. And I have the great pleasure to introduce for this section to our colleague Stephen Shongwi, who will moderate the questions. And I have been looking at the chat, and there are fantastic questions there, Stephen. So you had probably a difficult task selecting them. So Stephen, the floor is yours. You have about 12 minutes for this section. Stephen?
Thank you very much.
Yeah. And Stephen,
Yeah,
if you can put your camera a little bit down so that we can see you at this point. Perfect. Thank you. A little bit wider down would also help. So you can go, if you can go a little bit more down. So good. Now it's good. Thank you for that. Yeah.
Okay.
Perfect. Thank you.
Thank you very much, Alakos. Thank you very much, colleagues. Thanks, Jody, and thanks, Jim, for the last session. So I'm going to ask our panelists a few questions, which are based on the questions that were submitted by participants. So the first question is directed to Jody Mills. And the question is, the Rehabilitation Competency Framework is designed to be taken up around the world by any rehabilitation workforce. Yet what competencies a workforce needs and what activities they perform can be vastly different depending on the culture and environment in which they work and their scope of practice. How can the Rehabilitation Competency Framework be relevant to all rehabilitation workforce? Jody, if you could, and then other panelists can also chip in if necessary. Over to you, Jody.
Thanks, Stephen. I think it's such an important question, this one, for a framework like this, which is designed to be relevant for so many people around the world. I think it's important to highlight that the RCF can't just be directly picked up and used in any setting. It must be adapted before it's adopted. It's really acting as a launch pad for the development of really context-specific competency frameworks. And so it was designed to have features that make that as easy as possible. So the language that it uses is as universal as possible. It's conducive to translation, and it provides a framework or a structure that can be really easily applied in a range of different types of competency frameworks. But one analogy that can be useful here is if you think of the RCF being like a parent that's going to have lots of little baby competency frameworks in the future. And all of those children will sort of resemble or reflect the parent in some way, but they'll all look different. They'll all have their own unique features, and so they should. And I think we don't really want to create or promote a cookie cutter or a prescriptive approach. We really just want to be able to facilitate very context-specific competency frameworks. So I hope that answers that question.
Thank you very much, Jody. Thank you. This is excellent. The second question, one of the aims of the Rehabilitation Competency Framework is to better align the rehabilitation workforce with population needs. Apart from population shortage, how do you think the current workforce is failing population needs? And how do you think population needs will change in the future? What will this mean for competency framework? This question is directed to Jim. Over to you, Jim.
I think you might have to clarify which Jim, because we have two Jims.
Okay, Jim Campbell.
I'll defer to our guest, Jim Buchan. Professor Buchan.
We usually distinguish ourselves by I'm the Scottish Jim and the other Jim is the English Jim. The critical question, and it applies in any context, any situation. I think we need to recognize that population needs, well assessed, needs to be the main driver of determining what the workforce profile should look like. But there clearly are critical other aspects that need to be part of the solution. And that includes one that has been touched on, which is the distribution of the workforce in terms of geography, in terms of sector, so that it is optimally located to improve population access to healthcare. And that is a challenge that all countries are facing. None of them have solved it completely, but there are good policies around which can be applied to try and ensure that we at least move towards optimum geographic or sectoral allocation. A second issue which goes beyond the numbers also is the need for individuals and teams to be as productive as they can be. And that is partly about having the right mix of individuals with the right skills, but it's also ensuring that they are supported by the right sort of technology, the right availability of tools and equipment to deliver effective care. And I think one that has come through quite strongly recently because of the impact of COVID is that we need to be quite flexible and adaptive in terms of how teams work together, so that there is a rapid and sometimes changing response depending on what the priority population health needs are. We've seen very clearly these can shift dramatically quickly, and the workforce needs to be able to be flexible in its response and adaptation to such challenges. Thank you.
Thank you very much, Jim. This is very helpful. Thank you. So the next question is directed to Jim again, but Jim Bakken. What is the Rehabilitation Competency Framework especially important for less developed settings? So let me repeat the question. Why is the Rehabilitation Competency Framework especially important for less resource settings? Jim, if you could answer that one.
The Scottish Jim again. Yeah. The framework is relevant in any context, but I think it has particular utility and high level implications for less resource settings, be they countries or regions, because it allows the point I made in my initial contribution, it allows this part of the workforce to have better visibility, and it encourages policymakers and the population to develop a better understanding of the value of the contribution of the rehabilitation workforce. In some more mature settings, it's the older and usually larger health professions that are most prominent because they've been around longer. And particularly the medical profession is often well connected in terms of policy influence. I think what the framework can help do is level this playing field and ensure that the rehabilitation workforce is given full consideration as part of the overall policy response. And this is particularly the case in less resource settings where there are likely to be a very significant continuing staff shortages, so that the rehab workforce is considered as part of the solution even when resources are limited. Thanks.
Thank you very much, Jim. That's excellent. So the final question.
Jim wanted, Stephen, I think you couldn't see it. Jim wanted to compliment. Jim Campbell wanted to compliment.
Thanks.
Yes, please.
Stephen. So just 2 points. One, since Brexit, I consider myself the Irish Jim, not the English Jim. Has important characteristics around freedom of movement. But on the second point, I think what we recognize, if you look at the whole pretense of understanding what our population needs, we absolutely recognize that in all settings, there is a growing need for the rehabilitation workforce. And that all countries, high income, middle income, low income, all regions have to be looking at what is the workforce that they have, their competencies, and how they respond to those population needs. And this visibility in lower resource settings is going to be absolutely critical. We look forward to working with as many countries as possible that want to develop this work and implement it in practice. Thank you.
Thank you very much, Jim. That's excellent. We have a minute for the last question. This one is directed to Harvey Abrams and Mary Silcock. So there is a risk that documents like the competency framework sit on a shelf unused. How can we ensure that the rehabilitation competency framework is actually taken up and put to work? So over to you, Harvey Abrams and Mary Silcock.
So Mary, do you want to?
Yeah. Well, I think, you know, being aware of it and referring to it in our work, and starting to engage with what is the content, and really thinking about how to apply it and having a go. I think that is the biggest thing, and then making that visible and connecting with each other about how you found adapting it for the population, and was, you know, any tips and strategies or lessons learned, because it will evolve and really support that global community of rehab and rights if we are doing it together. Yeah.
So I don't know, this may be sort of aspirational, but I think the rehabilitation communities around the world need to develop some sort of a support structure in a way, so they can share their experiences, they can share what's working and what's not working, and particularly where they're being used for the first time. So I think this idea of a global support network is going to be very important as we move forward.
Thank you very much, colleagues. Thank you to the panelists. You've been excellent. So I now hand over to my colleague, Alakos. Thank you very much. Over to you, Alakos.
Yeah, thank you, Stephen, and thank you again to all panelists. And now, only from my side, 3 short messages. The first one, thank you. Thank you first to everyone who has accompanied us in this journey. It is about the technical working group, the respondents of the Delphi exercise, also the rehabilitation users responding to the survey, and of course to the many also colleagues internally here at WHO that have also contributed to it. Thank you also to the professional organizations that have been behind the rehabilitation professional organizations, the International Association of Logopedics and Phoniatrics, the International Council of Nurses, the International Council of Psychologists, the International Society for Prosthetics and Orthotics, the International Society of Physical Medicine and Rehabilitation, World Physiotherapy, and last but not least, the World Federation of Occupational Therapists. Thank you to all of you. Thank you also to our wonderful speakers and panelists. Thank you for being with us and for engaging with us, and also for all your knowledge that you have shared today with us. Thank you to you, all participants joining today, but also future participants looking at this recording in the future. Thank you for embarking also in this journey and accompanying us to move the implementation of the Rehabilitation Competency Framework forward. Second message, embrace it. We have here today imagined the strong message of unity that we could send to policymakers, to health planners, if all rehabilitation professions and beyond embrace this rehabilitation competency framework as a unifying platform to move this agenda of responding and planning accordingly, or the strengthening workforce to address the rehabilitation needs of populations. And third, please use it. Don't let, as we have heard today, to be this competency framework in the shelves. It has a huge potential, and please if you have the intention to use it, you can join the next 2 more technical webinars on how this competency framework can be adopted and adapted. And that will be on the 11th or the 25th of March. So you can go to our webpage and register. And so thank you, embrace it, use it. Goodbye, see you soon.
Thanks everyone, bye.